very good morning to all, our doctor fraternity, our doctors in Hyderabad and our doctor based out of Australia. Very good afternoon to him. Our webinar today is a masterclass of sorts. It's on anticoagulation, what we call insights into clinical management. The side effects and burden of anticoagulant treatment could end up in failure, possibly at some points of time. We may not be able to get the right fundamentals out of the treatment. Hence, to facilitate the cause, the Critical Care Division of Biological E Limited, in association with the Times of India, is bringing to you this discussion with Hyderabad's finest doctors. I'd like to introduce the panel before we begin. Dr. Badri Narayana Tumulu is a cardiologist and senior consultant cardiothoracic surgery at Apollo Health City, Apollo Hospitals, Hyderabad. Dr. Sanjay Kumar Agarwal is a senior consultant cardiothoracic in cardiothoracic surgery, also at Apollo Health City, Apollo Hospitals, Hyderabad. Dr. Sanjeev Kumar is a senior interventional cardiologist at Sunshine Hospitals. And Dr. Anand Joshi is into internal medicine and is a consultant intensivist and physician at Sunshine Hospital, Hyderabad, and Concord Hospital, Sydney, who is currently based out of Australia as we talk. So let us begin the session basically with the understanding of anticoagulants. Dr. Tumulu, can you please tell us what anticoagulants are and how they are different from antiplatelets like aspirin?
Good morning to all.
Good morning.
And thanks TOAB group. A nice masterclass webinar is a practical, very important for doctors and basic practitioners. The first question is anticoagulant, antiplatelets. By the name you see, anticoagulants to prevent clotting of the blood. Another is antiplatelets. This with dysfunctions in a platelet, which causes the inhibition of the platelet aggregation. So anticoagulants, the drugs, you know that traditional drugs like heparin, injectable, or coumarin or warfarin, NOACs, newly come. These are anticoagulants working in different protein molecules. Cascades of clot formation is inhibited. So that clot formation is inhibited or prolonged. Second, antiplatelets, the drugs, you know, the premier drugs, aspirin. Now the prasugrel, clopidogrel, these are antiplatelets which causes through different enzymatic mechanism to prevent platelet aggregation and coagulation, adhesion, which causes bleeding disorder, bleeding prolongation. Basic one is blood formation, clot formation. One is platelet adhesion. These are basic two different drugs.
So Dr. Sanjay Agarwal, question to you would be, sir, what are the latest advances in anticoagulant medication? What are the anticoagulants available today that can be used?
First of all, thank you for hosting me on this webinar, such an important webinar. Anticoagulants are basically grouped into two parts, oral anticoagulants and parenteral anticoagulants. Oral anticoagulants are of three types, that is vitamin K inhibitors, as we use the warfarin and dicumarol and acinocumarol. Second group of oral anticoagulants are factor 10A inhibitors. And third group of oral anticoagulants are direct thrombin inhibitors like dabigatran, which is a newer anticoagulants. Second type group is parenteral anticoagulants. It is also divided into two parts. One is the indirect thrombin inhibitors, such like a heparin, unfractionated heparin, what we use routinely. Second group will be a low molecular weight heparin, and third will be a fondaparinux group of thing. And second group in parenteral anticoagulants is direct thrombin inhibitor as biliverdin and libiwerdin. So these are the two groups of anticoagulants.
Fair enough, sir. Very, very elaborate. Thank you so much. Dr. Sanjeev Kumar, question to you, sir. What is an anticoagulation card and what is the importance of this particular card, sir?
We have seen that people are in anticoagulation, they are not being monitored very well. If you see, most patients do not reach the therapeutic range in 60% of population, at least in India, and 30% in worldwide data. So when the patients are on anticoagulation of any kind, they need monitoring every monthly, and more so with the older generation anticoagulation. That is like INR monitoring every monthly and visiting a clinic, because if INR do not reach in therapeutic range, the chance of valve thrombosis increase many folds. We have seen many emergency admissions by people being breathless and the valve getting thrombosed, and then the treatment remains either burst that clot with the medication or change that valve as such. So these patients are being very strictly adhered to this treatment, and the way they should, the monitoring has to be very robust, and it has to be made telephonic or a personal visits. So these cards help us in more compliance to the patient and monitoring them very well, because still our novel anticoagulants, Novax, which do not need much monitoring, are not being given for valve cases.
Fair enough, sir. I think it's quite elaborate. Thank you once again. Dr. Joshi, question to you, sir. During this pandemic, what are the risks if a patient on anticoagulant medicines gets COVID? What is the role of anticoagulation in critically ill patients, sir?
That's quite a wide thing to say, because I understand there are two aspects here. One is how the COVID impacted the coagulation in our body and what are the long-term effects of it. So coming back to your first question, what are the precautions or what are the concerns a person on anticoagulation person should take while on he gets infected with COVID?
Right.
In fact, it might be a kind of blessing in disguise, because the COVID has shown, the data has shown that it acts as a more prothrombotic state, and there are high chances that the patient with the COVID has high chances of getting the clots. We have seen in this is more on the arterial side clots. I would say that they get in terms of strokes, they get in a MI, they get in a peripheral vascular disease. All these things, if the patient is already anticoagulated, and probably there is already a partial protection going on. Now, there has been a lot of data and research that this concept, initial concept that the COVID is adding an extra burden of the clot. And because of that, the initial first year of during the first wave and the earlier part of this year, everybody was going that we should be anticoagulating every COVID person. However, in fact, the latest meta-analysis, that is as late as this 4th of August, the New England Journal has come out with the various trials data, and that has clearly suggested that there is absolutely no need to go a very high therapeutic range while giving the anticoagulation for the COVID-19 patients. So COVID-19 patients, if they are given a regular thromboprophylaxis, that is enough. Having said that, those patients who are requiring anticoagulation for some other reason, they should be continued to be given in the same dose and the same therapeutic range as a non-COVID. Critically ill ICU patient by default are high risk at developing clots, whether they are with the COVID or whether they are not with the COVID. And for them, thromboprophylaxis in the terms of getting the low molecular weight or heparin wherever appropriate is very important. It is, in fact, it is a part of the ICU culture that any sick patient who is coming to the ICU, who is getting ventilated, who's getting dialyzed, need to have this thromboprophylaxis. Otherwise, it's almost like a criminal not to have the standard guidelines. So for COVID, those who are already taking the anticoagulation, yes, continue to take. You don't need to have extra. For COVID and critically ill, thromboprophylaxis is enough.
Thank you so much. So we move to round two of our discussion. We come back to Dr. Tumulu once again with our round of questions. So what is COVID-19 associated coagulopathy? Is it different from disseminated intervascular coagulation, which is DIC, sir?
I will try to answer this.
Yes, sir. Yes, sir.
Okay, so in coagulopathy, clot formation, there has to be endothelial injury, which is proven beyond doubt in COVID patients. Endothelitis has been found in many autopsy studies,
Right.
which were not allowed earlier, but now few autopsy studies from France has proven that there is endothelitis,
Right.
which has led to this coagulopathy and increased clotting occurring in this COVID patients. More so as pulmonary artery thrombosis, which is very deadly, and most of the times people succumb to this.
Okay.
That is the reason when the people are critically ill, they are on full dose of thromboprophylaxis.
Okay.
Having said this, how different is DIC is that in DIC, it is more common is to consumption coagulopathy, where the parameters get consumed and the major presentation is a bleed. However, in COVID, the major presentation is a clot than a bleed.
I see. I see. So, so doctor, taking the question a little forward. So, how frequently do we monitor anticoagulation?
The most reliable of anticoagulation is that gold standard drug called heparin, which requires to be monitored every 6 hourly and to keep the APTT level within range. The low molecular weight heparin is to be converted when the patients are shifted out of ICU state and they are still requiring oxygen, still support. How frequently they are to be monitored and D-dimer to be monitored is when the D-dimer is raised, it is already parameter that the anticoagulation is needed and the body is trying to burst that class. So D-dimer, high D-dimer, higher the D-dimer, higher the mortality. The few of the parameters that change in COVID are rise in fibrinogen, rise in platelet counts, rise in D-dimer values, rise in factor VIII values, rise in von Willebrand factor, decrease in S level and more in C level. So all these parameters are not to be monitored. The only monitored parameter is D-dimer, and once it is raised, it does not need to be rechecked many times.
Okay. Fair enough, sir. Thank you so much. Dr. Tumulu is back, so we can just ask him a quick question. Sir, what are the alternatives to anticoagulation?
Alternate anticoagulation for treatment of A for see in some states
Yes, sir.
there is no alternative. You have molecule change only.
Okay, okay. The treatment is changed. Fair enough, sir. Fair enough. So we move to Dr. Agarwal. A quick question, Dr. Agarwal. Sir, can you share details about the pros and cons of new generation anticoagulants? Dr. Agarwal. Sir.
Yeah, new generation anticoagulants are basically direct thrombin inhibitors and factor 10A inhibitors. But all this role of new generation anticoagulants are basically a non-valvular case, because what we deal with the valve cases, we are going for a vitamin K inhibitors or heparin.
Right.
But newer anticoagulants role is only limited to a non-valvular disease like AF and this thing, critical illness care therapies. Problem is older anticoagulants you can monitor very easily and you have an antidote available for them. Newer anticoagulants monitoring is little difficult and antidotes are not very well established.
I see.
In case of suppose you need a urgent surgery in these cases.
Okay.
So it will be always a very difficult choice.
Difficult situation.
It is.
Fair enough, sir. Thank you so much, Dr. Agarwal.
Sir, if you permit me as a view, because he's a surgeon, and if Sanjay sir permits me as a cardiologist,
yes, sir.
The novel anticoagulants have actually entered in clinical practice. As a surgeon, I agree to his point that heparin, warfarin, Oral anticoagulants of oral generations are only being approved. The newer generation, rivaroxaban, apixaban, and dabigatran have not been used, but they have done wonders in a vast number of patients of atrial fibrillation. High CHA2DS score, that is, people who are diabetic and hypertensive elderly with atrial fibrillation. The best part is that they don't interact with the food. They have a very static effect. They do not need monitoring, and they are cost effective, even if they are costly in India. Now, how do I say so? Is in America, to monitor this and have a doctor consultation cost more than in fact, the cost of that novel anticoagulant. So if you say the cost effectiveness has been proven in many studies, that rivaroxaban, apixaban, and dabigatran have done better than their past predecessors in the form of the safety profile, the accuracy of anticoagulation, and no need to monitor. So in up to moderate mitral stenosis and the patients of AF, we still, as clinical practice, do recommend lot of NOVATs, novel anticoagulants, the safest being apixaban.
Fair enough, sir.
Yeah, I would pitch in on this, and
Yes,
I
sir.
completely agree with Sanjeev and Sanjay sir also.
Yes, sir.
Currently, there are no studies. Whenever a new weapon comes, it's always a big thing that this should not be an ultimate weapon. We always need to have an anti for that. In case this goes out of hand, then we need something like an antidote for each of them. The time tested vitamin K and heparin, we have an antidote. So it's very, very comfortable to be used in an emergency situation, in a complex situation where we would like to reverse the things when it goes out of hand. So that goes with what Dr. Agarwal deals with such a sick patient, and whenever need to go for a surgery and a perioperative, he will definitely be comfortable in something which has an antidote and which he can predict how it will go based on an objective parameter. You have a number in front of you, you have an INR in front of you, you have APTT in front of you. That gives the surgeon a much comfortable level. But having said that, this is not so comfortable for a person who is in the community. So for the physician, I want something which my patient will not be hassled every 10 days, 15 days, 1 month, that I need to keep checking the things. I don't want to hassle that, oh, I can't eat this, I can't eat that. So in that terms, I think newer oral anticoagulants, or they are no longer newer now, oral anticoagulants have really revolutionized the practice. I'm sure once in the future, we are getting some data, as the new oral anticoagulant starts getting antidote and their efficacy is proven even in the valvular, I'm sure Dr. Agarwal will also be happy to use them as the monitoring things goes down.
Time will get the answer. We have to wait for more studies to come. Now we have PCC, SEC administration to combat emergency surgery when patient are newer anticoagulant also. The option is there. Or you can wait 6 to 8 hours.
So we move to round 3 of our discussion with Dr. Tumulu, starting with him. Sir, what is the current role of anticoagulants in cardiovascular medicine, sir?
See, cardiovascular medicine, basically you have anticoagulant. One is post-surgery, number one. Second, valvular replacements, aortic, mitral valve replacement. You have to, when there is a mechanical valves, you have to give anticoagulation is a must. The second, when there is a rhythm problem, means atrial fibrillation. Patient having a permanent or persistent atrial fibrillation, you should give anticoagulation. These are two substances a must. Third, as a coronary disease, when you do angiogram, the thrombus is there. You can give anticoagulant for some period. LV clot, some period. Valve thrombosis. If there is a thrombus in the prosthetic valve, you have a thrombolytic and anticoagulation you have to give. These are few. Where there is a thrombus, there is a role of anticoagulation, either prevention or as a therapeutic. The anticoagulation variety already we have discussed. It may be few days first parenteral, then you can switch off to oral, few days, few months, as per the scenario. If you wish vitamin antagonist with INR evaluation, you can continue. or you had a newer anticoagulant or directly acting oral anticoagulant, which doesn't require so much monitoring, but periodic clinical checkup is usually required and follow the medicine. So basically, when the rhythm problem, when there is a mechanical mark, and there is a thrombus, either coronary artery, peripheral artery, or LV clots, the anticoagulations are indicated in practice of cardiovascular disease.
Thank you very much for your very elaborate explanation, sir. Coming to Dr. Agarwal, can a person with a prosthetic heart valve use NOAC, that is the novel oral anticoagulants? Are there any reversal agents available for NOAC agents, sir?
Still, this for prosthetic valve, NOAC is not very widespreadly used. There are few studies going on, but final result is still not available. So, being a surgeon, we are always little conservative in our approach. So we stick to IV anticoagulants and followed by oral anticoagulants in prosthetic valve.
Perfect.
Yeah.
Perfect.
So once, with your permission,
Yes, sir.
After Novak did so well in atrial fibrillation and so well control of anticoagulation cascade, there was a lot of enthusiasm in checking post-valve Novaks. And this study was done with dabigatran, and this study was stopped earlier. The reason was a lot of valves were getting thrombosed. After that, for a long time, nobody had a courage to give only Novaks to population with valve thrombosis. However, when it was tried with mitral stenosis, rheumatic heart disease, up to moderate mitral stenosis, they have found that they were effective. But nobody still had the courage to start a study with only Novak till now because it causes more thrombosis and more mortality.
But that was a native valve preserved in place, not the artificial prosthetic valve implanted.
Going back to Dr. Sanjeev Kumar, sir, what are the various thromboembolic complications seen in COVID-19 and post-discharge?
So rather than what is given in the book, let me start with my personal experience because it increates more memory.
Yes,
so Anand sir gave me a call and said that when patient in ICU is having chest pain and ECG is showing ST elevations, the most common that we saw and we treated were ST elevation MI. Most of them, I don't know why, they were inferior wall MIs. Probably because of inferior wall MIs causing hypotension and slow flow that led to thrombosis. And the data says that the MI should be tackled in the same way as per ACS protocols. ACC, AHA have set the guidelines that there should be no difference in managing the patients in COVID-19, except that you can thrombolize those patients and buy some time till the results are awaited and do not waste the golden hour. So we did stunted few patients with inferior wall MIs during COVID-19. That was one subset. The second very, very drastic subset was deep vein thrombosis. Even on anticoagulation, even on heparin, we saw few DVT and that led to sudden pulmonary embolism and patient collapsed. It is very difficult to do a pulmonary pulverization procedures during COVID-19 because patients are generally very sick and difficult to mobilize to cath lab. So pulmonary embolism prevention was a very important aspect, and few of them with Anand sir, we did thrombolize them also, but the mortality remains so high. The third most important complication, a precursor of coagulation, was an atrial fibrillation coming in because of hypoxia and various other reasons. There were increasing incidents of AF during the hospital stay. These were the three major things that I saw during COVID times.
Interesting observation, sir. Very interesting.
I think I would like to add on this. Like, besides this, we also came across the strokes. I mean, brain stroke causing the paralysis. There, I don't remember anybody particularly with the bleeding because they were always ischemic strokes. And the second thing where the peripheral gangrenes were also noted. Now, peripheral gangrene, I would suggest that they were seen in more of very, very sick, intubated, ventilated patients It might be a part of the DIC profile that might be happening. But yeah, besides what Sanjeev have said, brain strokes, ischemic strokes were also common.
So sorry to interfere. We've seen a couple of cases of pulmonary artery thrombosis, not embolism. Thrombosis. Now, so arterial thrombosis, venous thrombosis, pulmonary artery, they are all documented. In upper limb, lower limb arteries are affected. So almost all vascular trees, irrespective, maybe MI, cardiologist, but peripheral vascular disease specialist, they must be encouraging. We have seen a lot of lower limb thrombosis like common iliac artery, SFA thrombosis. Before gangrene also, they came into acute limb ischemia. We have dealt also. Results are very, I think, not as good as atherosclerotic, what we are seeing, peripheral artery disease.
I think that is a part of that. That was a part of the spectrum of what Sanjeev have rightly described as endothelitis.
Yeah.
And with as we got matured with the treatment of the COVID, with early and extended steroids, followed by aggressive remdesivir and thromboprophylaxis. I think these things in the second wave we are not seeing now. Whether that was a part of alpha variant which was causing more, and the Delta variant is not causing more, we are not sure. But I guess now in the second wave, we are seeing less and less of this thromboembolic thing and strokes and MIs thing, rather than as compared to the first wave, I guess. What do you think, the panel?
Yeah, the incidence may be less, but it is occurring sporadically, not zero.
Not zero.
Maybe, yeah. Maybe variant effect, or patient may be received as soon as some suspicion, they have received some antithrombotic or anticoagulant drugs. Now it is rampantly available, even over the counter India available all the drugs. They suspect corona, immediately they give a package, corona package. This much of drugs will take.
Yeah, that's true.
Dr. Joshi, coming back to you, what is to be done if there is any emergency like surgery for patients of anticoagulation?
It's almost the same as getting it repeated. Okay. Like we are talking about the antidote for the thing. Okay. So if the person is on warfarin or vitamin K antagonist, then we do have its reversal in terms of vitamin K. Okay. And then we give the FFPs and platelets and coagulant concentrates we can give. Okay. Basically, FFP and cryoprecipitate are the one which will reverse to the INR, because that we have an objectivity. Okay. Heparin, we have antidote for that, protamine, which can be given to reverse that. Low molecular weight heparin is where the issues are. We don't still have any obvious or direct low molecular weight heparin reversal. Having said that, there are some newer molecules which are coming up that may help to reverse it. We still rely on stopping, if it's an elective surgery, we still rely on stopping the 12 to 24 hours of the dose, because they get out from the circulation. And we may attempt in giving them again the FFPs and cryoprecipitate if the surgery is very, very emergency. For direct or oral anticoagulants, I do have that. For dabigatran, we have idarucimab. It's quite a tongue twister, but we do have an antidote. But again, these things have to be backed up with the FFPs and platelets and other plasma to supply the procoagulant factors.
Right, sir. Thank you. We move to round 4 of our webinar today. We can start with Dr. Tumulu. Sir, to avoid serious drug interactions, what are the drugs to be avoided during anticoagulant therapy?
Anticoagulant therapy, again, we have discussed drugs two ways: vitamin K antagonists and directly acting oral anticoagulant drugs. Only drug-drug interaction, food interaction will more vitamin K antagonists like warfarin and coumarin. They are all like with grisofulvin and this anticonvulsant drugs, carbamazepine, and we can be verapamil. These are all the drugs, and green vegetable, vitamin K containing foods should be avoided, so that it will not interfere with vitamin K antagonists. But directly acting oral anticoagulant drugs, they don't have much drug interaction. Only renal parameters to be seen. If there is renal dysfunction, those to be adjusted. And drug interaction is very less with directly acting oral anticoagulants. And it is very when you are giving vitamin K antagonist, we should be careful giving drugs. What are the mixture drugs? What are polytherapy when you give other drugs to avoid it with vitamin K antagonist like warfarin and Kumar, tricyclone, like these drugs.
Next question to Dr. Agarwal. Sir, can you share details about oral and injectable anticoagulation, sir?
Yeah, oral anticoagulations, as I told you, it is three group. Basically, most common use is a vitamin K inhibitors, which we use in our valve surgeries. But oral anticoagulants usually take 3 days to manifest. Matlab, for peak action to come, it at least takes 72 hours. So in that 72 hours gap, we start with injectable anticoagulants such as heparin or low molecular weight heparin to tide over that 3 days. By that time, the oral anticoagulant effect is manifested nicely.
True.
This is our protocol, how we go on a anticoagulation involved cases.
Dr. Sanjeev Kumar, question to you, sir. What are various anticoagulation drugs prescribed during COVID-19?
So the most research that occurred during this time was with the drug called apixaban. Apixaban was initially tried at 2.5 mg BD, and this occurred actually because 17% of individuals who were discharged from the hospital came back with some way of thrombosis. They had peripheral thrombosis or pulmonary artery thrombosis, and they were dying suddenly. So this study looked at which is a safe oral anticoagulant which patients can be sent home. And as per data, they approved it for 6 weeks. The dose of apixaban at 2.5 mg 2 times. And the best part is it has no interaction with most drugs that were prescribed, antibiotics. It has no interaction with food, and it has very less among its class GI bleeds. So it was a fairly safe drug, and it was given for 6 weeks. And we have seen the more open use of oral anticoagulation in second wave has actually decreased those deaths which were patients were being discharged from hospital stay.
Thank you. Very, very comprehensive once again. Dr. Joshi, question to you, sir. How to manage triple anticoagulation in post-angioplasty patients?
Oh, well, I think Sanjeev is the best person to answer this question.
Maybe Dr. Sanjeev can take it forward.
It's his, that will be
that's his domain specialization.
Yeah, that will be his bread and butter.
I agree that Anand sir is always there with me after my patients are being stunted and shifted to ICU. And two important scenarios that occur post MI is onset of AF. And the second is a very bad LV which has an LV clot. Now, in these both scenarios, there is a clot already formed where antiplatelets are not going to work. And giving two antiplatelets already pose a very high risk of bleed. Shall we add a third anticoagulant agent? So Anand Joshi always adds heparin or low molecular weight heparin during the hospital stay. What happens when they go home? The guidelines suggest that you can give two antiplatelet drugs with a novel oral anticoagulant and give it for 6 weeks. Look at the echo. If the AF episodes, try to convert AF into sinus rhythm and look at the LV clot. If the LV clot disappears in 6 weeks, you should come off this third anticoagulant dose. Otherwise, you can continue it for 3 months. After the 3 months, the bleeding risk increases substantially. If the person still have a residual clot, you come off the one aspirin, that is antiplatelet, be on one antiplatelet and one anticoagulant for a longer time.
Thank you.
There is just one small attachment on this. Many times we get confused trying to equate antiplatelet with anticoagulant. As the first question Dr. Badri and Anand had already explained, people need to understand that there is a difference between what we call it as a red clot and there is a difference between a white clot. So red clot is what we get on the venous side with low stasis and lots of RBCs, and there is a lot of fibrin in between. And because of the stasis and the fibrin and all those things, you need an anticoagulant for that. The white clot is essentially what you get in the arterial side. So your strokes, your heart attacks, your peripheral vascular disease, getting gangrene, all these things has more of platelets that get stuck to an activated endothelium. And because of that, the initial event is not of the coagulation factor, but of the platelet stickiness. And hence, you are benefited by antiplatelet on this time. When the anticoagulation goes to a very high level, then probably there is some scope that the antiplatelets can be managed without. But I guess these two things are different. The antiplatelets, which are required for the stenting, and the anticoagulants, which are required mainly for the venous thrombosis.
We move a little forward with Dr. Tumulu once again. Sir, what are the problems with warfarin?
See, first is interaction with the drugs. So many drugs are there. I already enumerated few drugs. Interaction with the dose, you have to adjust or increase. Second, it needs frequent monitoring, which is always difficult in the Indian context, because so many areas are the top of hills, bottom of the ocean, our villages are there. People are diseased. To give warfarin, they are not followed up. So either underutilization or overutilization means the dose may be less, they're more thrombotic, the dose may be more, there may be bleeding risk there for the patient. We are not able to control that. Second is, the most important is food also. Even you are Indian, see, green leaf is those vitamin K content foods, people are not aware. So they are taking with this warfarin, the dose is, the drug's efficacy is reduced, so that they are more prone to thrombosis. This is the main two disadvantages: interaction with the drugs, interaction with the food. Second, frequent monitoring and adjustment of the drug. These are basic difficulties in the treatment with VK testing or warfarin. Other things, I think acceptable. Cost, other things acceptable. But these are two main things to me. Even above elderly age also little more risky than directly acting oral anticoagulants.
Thank you. Dr. Agarwal, sir, for you, what is D-dimer and what is its role in patients with COVID-19?
D-dimer is an inflammatory marker, as Dr. Sanjeev Kumar have already described, because all the inflammatory markers are going up because of the pan-endothelitis in a COVID. And there are multiple markers, but the most common marker which is monitored is a D-dimer. It shows the level of inflammation which have set in a body, and accordingly we have to monitor the doses. So how much inflammation
it is basically
parameters are there in the body.
True.
So according to which we have to monitor our steroid doses, then we have to go for anticoagulation, then all the other supportive measures. Anti-inflammatory drug like tocilizumab, and these all drugs we have to monitor depending upon a D-dimer level. And it also gives an idea about a prognosis, how the patient is going to recover.
In addition to Mark, I want to add, it is a fragmented particle of a protein. It also suggests extension of thrombosis, DVT, other things. One is a marker, inflammatory marker. Second, extensive areas of thrombosis, how much extension affected. It indirectly says the prognosis.
Dr. Kumar, Sanjeev Kumar, sir, question for you. Is there an increasing need of anticoagulant therapy in prevention of arterial fibrillation?
Oh, arterial fibrillation was revolutionized by Novax. The reason is that the hypertension and diabetes, India is supposed to be the second biggest burden of disease in the world. If you would say the number of patients of AF which are undiagnosed are 60%. There was a recent study called Apple Heart Study, where Apple Watch was used to identify innocent AFs which occurred When the patient was in getting an ECG done, it was not picked up. So these innocent AFs were more cause of clots and CVS. And the reason was, during AF, the LV will not move and the clot will form. When it will go to normal sinus rhythm, it will push that clot out. More easy to manage a patient with the chronic AF, this anticoagulation won't be needed. In chronic valve cases, we see, even for chronic valve cases, we see patients coming down for a long time not taking anticoagulation. Still, they do not throw a clot. However, a young innocent person with a very incipient AF also throws a clot. So picking up those patients was a big challenge, which has occurred during COVID times, where good monitoring devices, Holter devices, which were portable, were available, and to the introduction of NOVAX, which actually reached to almost all the pens from MBBS to MD to super specialty, and across all the super specialty, being so less need of monitoring, easily available, and cost effective. So the novel anticoagulation have actually started their phase and revolutionized themselves with the advent of AF only.
Just to continue the discussion, are we seeing more of the thrombosis parts now with the COVIDs? I guess it's significantly come now.
Because definitely, as you said, the second wave, when only two drugs which were decreasing the mortality was this low molecular weight heparin and steroids. And now it is being so universally given that as soon as the patient admits or in ICU setup, the first thing that we do is we do not miss on these two drugs at least. And that is a reason that very, very less MIs and very, very less non-ST elevation MI are still available. But that gangrenes, thrombosis, pulmonary embolism has actually fallen down. The number has decreased.
Yeah. Because this is contrary to what we saw, Sanjeev. The latest study, which with especially the meta-analysis from the 3 big trials, they have not shown any major statistically significant mortality benefit and outcome, or 30-day or 90-day benefit when you are giving to a therapeutic dose versus a prophylactic dose. So that was a bit surprise for me. Maybe they are looking at a larger picture rather than the cohort of people who had a cardiovascular complication. Because, last year we really were terrified that the people are coming out of their COVID hypoxia, but then they were literally crashing in front of us, either with a stroke or an MI.
Yes, I agree.
And the second NSTEMI, which we are suspecting, I think they are more of a type 2 MI nowadays because of the demand and supply. I think that might be the case. See, properly rise.
Most of the guidelines says that if it's NSTMI, manage conservatively during COVID times and get an angio done before discharge.
Yeah, that's true. Having said that, we haven't done too many pulmonary angios to see whether, as what Dr. Badri Narayana was saying, whether we are getting this primary pulmonary thrombosis.
Yeah.
Because we don't have a way unless we do an echo. But again, echo will be problematic, that even in hypoxia, you will get a RV strain or RV dilatation. Severe hypoxemic patients which we have. It will be very difficult to say whether.
If you give 2 minutes, I will narrate a real, practical, actual story.
Yeah.
A teacher from Warangal, a 34 years male, a 36 years male, named Swarup Reddy. He was treated for COVID in month of May, first week, recovered, discharged home. After 10 days, again he had atypical chest pain. Some ECG changes. Local cardiologist in Warangal, some changes to lead 1 and AVL, some that is rough. Some elevation they thought. He thought of lateral MI. He thrombolized with plates. Daytime. He happens to be a brother-in-law from an ex-resident who is now a geriatric psychologist in UK. He hammering me. Then after the thrombolysis, the story went, he had hemoptysis, 4 bouts. Okay. Then midnight he called me. He shifted to Apollo Hospital Jubilees. By the time they reached here, it became 4 a.m. When I saw the patient at 4, 5, 4, 10, I was not convinced about that MI thrombolysis. Anyway, that part is different. Patient relatively stable, no pain, but hemoptysis is going on. So I've done an emergency pulmonary CT angio by 430, 450, clear cut pulmonary thrombosis and pulmonary infarction.
Oh,
We involved our interventional radiologist, pulmonologist, and original radiologist over the diagnosis. Post the pulmonologist told that the pulmonary thrombosis is a sequelae, post sequelae to COVID, which he had 3 weeks earlier. Some anticoagulation is stopped or underestimated local treatment after he developed pulmonary thrombosis. Then the other stories I will not say. This is the actual story of a patient.
yeah.
And, the more unfortunate thing, after diagnosis of thrombosis, 2 weeks treatment, and his mucormycosis as a positive.
Right. Okay.
Yeah.
So it's very difficult to say whether it was actually the COVID or it's the mucor that might have caused the pulmonary.
My first mucormycosis is negative, first, the day one.
Okay.
But pulmonary thrombosis, CT scan. After 10 days, mucormycosis is positive.
Okay.
Until same lab, same hospital, same thing. This last.
But I guess
So-
as against the international guidelines, we are stretching the steroids and its dose for pretty long time. I mean, pretty long. I guess 6 to 8 milligrams of dexamethasone given for 10 days to 2 weeks or till the patient is intubated. I think that's all. They should be removed from the steroid as soon as possible.
And after 2 weeks of treatment, mucormycosis, he had a pulmonary resection also, surgery also done. Huge gangrene parts.
Wow.
So, Anand sir, the next question is anticoagulation and vaccines. People who are on anticoagulation, should they take vaccine because they are very scared about it?
The two things which Sanjeev, I feel will be bothering people or any practitioner is that if I am a blood thinner by a blanket, we are not supposed to give any IM injections. So the possibility of the hematoma and the swelling is what we are concerned. I guess that has already been negated. The vaccine is given as if it's given IM, it's the gauge of the needle is very small. I guess the chances you will be really unlucky to get a big hematoma. But still, it's work on that. And
so, benefit and doubt, if your disease is acute pulmonary embolism, probably I will not ask them to stop and check an INR. If their INR is in range, it is very unlikely to cause a bleed. And as you said, that novel anticoagulants don't cause that amount of bleed. So I think it is fairly safe to tell our patients that even if you are on anticoagulation, go ahead with vaccine.
Yeah.
And the second if INR is around 1.5, they can very safely take a vaccine and we just instruct them to press the area for half an hour.
Yes.
That's all. And then hematoma incidence is practically negligible.
So another question is aspirin versus Novax.
No, before that, Sanjeev, there was here in Australia there was one this AstraZeneca vaccine. What we have, the Covishield one.
Yeah.
So there was a concern that those people who were above 60 or who were less than 60 with a bit of comorbidities had developed DVTs. And
thrombosis, peripheral artery thrombosis,
peripheral arterial thrombosis, and then that led to a larger what we call it as I won't say a rumor, but a larger concern among the people that whether the vaccine can cause the thrombosis, and but however the incidence of that has been so less or so negligible. It's 1 in 1 lakh or 2 lakhs. I think in India we would die before the chances of we dying by a road traffic accident or a TB was much more higher. So I guess this again brings up the fact that if you are to choose a vaccine versus no vaccine, definitely vaccine, even if you are thinking of having a thrombosis, because the chances of it happening is very, very less.
Thank you, Anand sir. With that beautiful note, I think we should close this discussion.
Yeah.
Dr. Badri sir, if you want to say something before closing.
No, thank you. Nice discussion. We have almost covered, especially COVID scenario. The most difficult question, patient and anticoagulation, we have taken the vaccine taken or not. to add that you can specify anticoagulation with warfarin, anticoagulation with NOAC. With NOAC can safely take. With warfarin. So for the home take home message is do INR to me. Do INR. If INR is normal, don't stop. Initially, what it was the instruction stop, DK, on warfarin, again INR 5 days, then give vaccine. I think do INR, it is normal, go for vaccination. I think this is okay.
So,
Yeah.
thank you, colleagues and friends, and thank you, Biologically, for all of
Yeah.
us to give this opportunity during COVID times to educate patients and the doctors and the community for sharing our insights and what we learned over last 2 years. Thank you, Biologically.
Thank you.
Thank you.
Sanjeev ji, and namaste to everybody.